So it is week 8. You already did your quiz. Remember, it is that clinical pediatric assessment assignment where it is 3 sections, okay? Make sure you ask me what topic that you're doing, if it's okay, so that I have a variety of topics and not just 2 or 3 that are generally picked, okay? I've gotten some interesting ones, so really pleased with what I'm seeing so far. Now, if you turn it in early, I will check it early and I will tell you where you can improve it so you can get a better grade. Okay. I use this as more of a learning experience on how to do a project, how to do proper APA, those references. I don't go crazy like psycho on APA, but as long as it's, within guidelines. And I know that many of you living in this town, you've got to go on for your bachelor degree, especially if you want to go into Baptist hospital system. It's one thing that they're looking at. It's all about um, you know these Baptist, Miami Children's. I mean, all of them today are looking for those certifications and those higher degrees. So this is what we call that. Run through on showing you how to get a project done and how to do it well. Okay. So that's what I use it as. So get it to me early, let me know, and I'll correct it for you. And then just resubmit it. So that is what I will do for you. It is 6% of your subjective grade. So it is counting a lot. I have had students not get it done and are like this close to passing, and they passed all their grades, all the this quarter. So make sure that you do get it done. I'll be sending reminders. You know how I work. And there is also a HESI pediatric assignment exam due too. Okay, so get that done and 50 NCLEX questions. As I said, next week we'll be starting your exam 3 reviews. As I said, I'll be putting it up. I didn't do it yet. Actually, I was doing some discussion questions, getting them done that I hadn't finished completely. And I'll be putting them up when I put up your announcement. So you'll have all of that information and you can copy it, do with what you like with it. And I think that it'll be good. I've gone over that exam 3 study guide myself. I've added, subtracted, put in, and made it what I think is everything that you do need. So it's there for you. So tonight we're going to go over some interesting topics. GIGU, a lot of stuff. Now, did you all have a chance to download that matching worksheet that I put out? Were you able to do it? Let me put it here in the box for you. It is, I've gone through the text. This is how I did it. Gone through the text, looked at all of the diagnoses, and for GI and GU chapters, those important things. And what I did is I made a matching from it. These are topics that you will need to know, whether for your exam, for your HESI, or your NCLEX. These are those topic. So I had it there for you. So it's now in your chat box. If you didn't get it, download it. I always send you the answer sheet when I send you your recording. So either tonight or first thing in the morning, I'll be sending you those recordings and the answer sheets. And it's those quick, brief things. What do you need to know about those diagnoses? So it does help you, okay? I used to use it as a quiz when I was on ground, trying to have students if they could understand what was what. So it's 20 different topics. All right, let's go and start with our PowerPoint. Very colorful, has a lot of different, diagnoses on it. GI, GU, there are quite a bit. So it is trying to keep it straight is the hard thing. Any questions before I continue? All right, GU. Let's start with the urinary. What goes on? Well, when you think of urinary tract problems in children, number one, you don't think of all those big things. You think of number one, urinary tract infections. most common thing that you see with children. It's hard to keep them from getting it because of the way children are. You know, little girls, tight little tights that they wear. It gets hot there. They don't wipe well. They don't drink enough. Boys, uncircumcised. You know that the mother doesn't pull down the foreskin, and that schmegma collects bacteria and it goes down the urethra and causes infections. So it's one of those things that children do get. And one thing that as nurses we need to remind our parents is to make sure that these children finish all their antibiotics. They tend to, oh, they're feeling better. It's a chore to get it down them. I'm going to stop. And they're going to end up with chronic or constant urinary tract infections. And we know that can cause problems, you know, with pyelonephritis and kidney damage. So how do you know a kid has a urinary tract infection? Well, you're going to be able to tell. That kid's going to be wiggling a lot, running to the bathroom a lot. It's going to be holding their area there. They're going to be incontinent when they are potty trained. You're going to see some of that very strong, horrible smelling urine. And you can, as I said, that frequency, urgency, and you'll see it redness down there. So parents need to know what it is and what to look for because if we get it quick, it's not going to affect the kidneys, right? And we know, especially younger children, their immune systems aren't that strong yet. So it's important that we do catch them quick. Now, children, they need to know how to wash hands, right? How to clean from front to back. And adolescents, as much as parents, we don't think our little girls are going to be having sex. We know that it happens. We were adolescents once. And we know that if they urinate soon after sex is possible, they're going to have a decreased chance of urinary tract infections. And if we get an adolescent who's having a lot of urinary tract infections, it's something that I would mention to them, you know, to try to help them decrease the incidence. Now, once we get all those signs and symptoms of urinary tract infection, how are we going to make sure that we're treating it properly? Maybe it's due to other stuff, not just an infection. Well, that urine culture and sensitivity is very important. Now, on young infants, we're going to do a calf specimen. Why do we do that? It's like, oh my God, they're going to put a tube there. It hurts. And parents get really upset with it. Well, think about an infant's immune system. Their immune system is not as strong as it should be. And if we don't get the correct antibiotic at the first time, and it takes 2, 3 times because we keep bagging this urine and we're just getting body contaminants, that those kidneys could be affected and you could have permanent kidney damage, right? So let's do a quick have the parents talk to the baby, do a quick little urine cap. It is a great sterile specimen as much as we can. And now we have a great culture and a great sensitivity. And we could say, okay, the antibiotic, we put that child on, it's going to work. And that's why we do that calf on infants. Now, premature babies are too tiny for the catheters. So we do what we call a suprapubic aspiration. And literally, they put sterile gloves on, they clean right above the symphysis pubis bone, and they put a needle directly in. And they pull out just a little bit of urine. And that's all they need. Now, does it hurt? Oh, probably yes, it does. And premature babies, do they feel pain? Oh, yes, they do. Now, most premature infants are intubated, they're on some sort of sedation. We would give them a little extra before we did that because we know by the heart rate up and blood pressure's up, you know, this baby hurts with it. So we are pretty good about that. And then there's all sorts of procedures we can do to check. We can do kidney taps if we want to look right into the kidneys and see what infection. We can put fluid into the bladder, wash it out, put a catheter in, wash it out, get all the excrement, see what's happening. Avoiding cystourethropy is usually done with that toddler, preschooler, chronic urinary tract infections. And we want to see, we put a catheter in, we send them to a CAT scan or into X-ray, we put dyes in and see does it reflux up the ureters into the kidneys. And that looks for all of those sort of structural things. And then an IVP, kidney stones, right? And then you could do renal scans. Now, renal biopsies. There are times we do renal biopsies, and it could be that child with persistent urinary tract infections, pyelonephritis, always with big elevated white counts, or the white counts don't come down. We want to look at those kidneys, see what's happening. So, this is extremely similar to a cardiac cath, and I'll tell you why. There's a pressure dressing, it's bed rest for 24 hours, and with this one, we don't want the urine, the clot where the urine or the blood, when we went to that kidney, we don't want that scab to come off. And we don't want it to drain because it can drain inside the peritoneum too, the peritoneal cavity, and it could cause some discomfort there and it could bleed. So we will medicate these children. They're always sedated for these things. We don't want them awake, course, always vital signs, before any procedure. When it's done, that pressure dressing or a sandbag, 24 hours, they're going to be on bed rest just to keep that clot from being dislodged. And then because it could go bleed or have urine oozing inside that peritoneal cavity, that's why we look for that abdominal pain. And we've messed with a kidney. We're going to monitor intake and output, okay? And infants are so tiny, sometimes we do have to have an open little incision to look. Now, as I said, that cystourethography is looking for things that are problems with kinks and stuff in the ureters or in the kidneys. We could see one ureter, both ureters, we could see hydronephrosis, all of these things we could see with that. And these are pictures. So the bladder is called a vesicle. So we have ureters and we have vesicles. So vesicle ureter type of obstructions. So when you hear those words, just know where they came from. Now, this is a syndrome. It's called nephrotic syndrome. I'm going to say this 3 times. It is not kidney failure. The kidneys work. They produce urine. It's not kidney failure. Has nothing to do with kidney failure. This is the kidney saying, yuck, protein, I don't like you, and spews it out. And what do you see? All the protein in the body is in the urine, and it looks like a foamy beer. That's exactly what this stuff looks like. Well, you're getting rid of all the protein in the body. Think about the protein in the blood system. That's being pulled out, and that's also getting disposed of too. So you see not only that proteinuria, of course, but hypoalbuminemia, which means no or little protein in the vasculature, in the blood system, which means all fluid is going pushed out intercellularly. These kids are massively swollen, big puffy eyes. They could have edema everywhere. This is just what you'll see with a child with nephrotic syndrome. So you've got a kid who's swollen, you've got no protein in their blood system. Got to be careful giving medications now. There, is no protein to hop on. So all the drug or most of the drug is free flowing. So that means you need smaller doses of medications. Now, nephrotic syndrome is for life. There's no cure for this. But what we do is we treat this child, on a daily basis, which is we're going to try to prevent infection, wash your hands, right? Teach this child how to do it. These children, because they get swollen in their mouth and the gums, they lose their appetite. So not only in their face, it's in their gums and they're biting on their cheeks, all because of this puffiness. So they don't feel like eating. Now, we will, because of all the fluid, what do you do when you're overloaded and you're edematous? Salt restriction and fluid restriction. And we need that family to understand what the importance and why that is so important. So, as nurses, what's our goal? Well, we want to make sure that we stop the protein from coming out. We use steroids to treat this. Which you're saying, but steroids can cause weight gain. Well, in this case, it helps the kidneys and it stops the protein from being excreted. Okay. We get that fluid out of the extracellular into the intravascular and we try to get rid of it. And how do we know all of that is working? Well, we're going to do daily weights, right? They're losing weight. Guess what? You're getting rid of fluid. And of course, intake and output. If we are doing a strict intake and output, we'll see it. And if not, we're going to see it in the daily weights. Now, acute glomerulonephritis is another strep problem. We talked about rheumatic fever, right? It's because by strep. Well, acute glomerulonephritis is something else. They're saying some strep things and maybe some other sort of infections, but most of all, let's say it is the strep, and it's usually within 3 weeks of after symptoms. Now, what do you see with glomerulonephritis? Now, this is acute, which means it happens and it goes away. Okay. At times it can become chronic and lifelong. Okay. What do you see? No urine. You're swelling up. You're swelling up. Your blood pressure goes up. Very similar when you talk about kidneys. You always worry about hypertension, right? So, same type of thing here. Now, the hematuria is dark, it's red, it's bloody. These are what you see. The protein is also increased in acute glomerulonephritis. So these children usually come in because they're all swollen and they stop urinating, is usually the symptom. And then we take the blood pressure and we find it. So, as I said, some of these will treat the strep, will get rid of it, and will symptomatically treat them. And then some of them just don't go away. Usually, they say if in a year of treatment, it's not gone, it's probably going to be chronic. So, something that's going to have to be looked at. So, again, how do we treat this? Well, daily weights, intake, output. And because it's the kidneys and the abdomen and swelling, we're going to do a daily abdominal girth measurements. And as I said, low sodium fluid restrictions on these children. We want to do everything to try to get rid of that extra fluid. And again, they are immunosuppressed, susceptibility to infections. Keep them free from infection. Wilms tumor. It's an adrenal tumor. This is common African American boys, usually ages like 3 to 5. And I've seen one in my lifetime. And it's a kid who came over from Haiti from an earthquake. And this boy came in, only spoke French. The people who brought him didn't know why. They came from a religious group who got him here. And the records were all in French. So I'm sorry, I don't speak that much French to understand medical records. So I did an assessment. And of course, now how do you get on this little 3-year-old boy's level? Because this kid was 3. I had to sit down below him, give him stickers. I would show him things and I have him help me. And he did an assessment with me really well. Because even not knowing the language, you can get on these level with these children. I mean, stickers are the best when you work with children. When I did an assessment on his abdomen, that left lower quadrant, it was the size of a softball. I felt this big, stiff solid something. And I knew it was this nephroblastoma, a Wilms tumor. Now, what do I need to now know and pass on to the next set of nurses to take care of him? Because I'm triage. I'm putting him into the ER now. This tumor is extremely fragile. And if you manipulate it, little pieces will come off and go into the peritoneal cavity and it will metastasize. Okay. This is why they don't even do biopsies on this before surgery, because they don't want that to happen. So they do chemo, radiation, one or both. It depends on the surgeon, size, et cetera, et cetera. And then they go in and remove it. Now, they go from the front, and where's the kidneys? Way in the back. There's a lot of manipulation in those intestines. So we have to worry about paralytic ileus post-op. Also, we've just touched the kidney. So we're going to worry about urinary output, right? So those are things we worry about that. Now, renal failure. Renal failure could be acute that happens for whatever reason, or it could be chronic. One of the biggest causes of acute renal failure in children is severe dehydration. That's how severe it is for a child to get behind on fluids. We don't want that to happen. So chronic, they're born with it usually, and usually it's this congenital. Acute could be due to medications, could be due obstructions, could be due to other different things, and they're all different reasons. So acute renal failure is when they stop urinating. They're unable to regulate the volume and composition of urine. As I said, not that common in childhood. I've seen it more in adults. And one thing that I saw cause acute renal failure with BUNs and creatinines, I think the creatinine was 12, BUN was over 100, was on a gentleman who was actually a friend of mine who took ibuprofen and took too much and not enough time in between. And ibuprofen caused him to have renal failure. And when they stopped taking, because he had kidney stones, because he hurt, could have taken many other things, but he took ibuprofen. Well, he stopped urinating, went to the ER. And after 3 days, he was about to get the dialysis catheter and everything. He started to urinate. So medications are stuff. Diseases, think about lupus, right? All of those things can cause problems. Now, chronic renal failure is when the kidneys are 50% of their function. And we know that the kidneys will continue to function less and less over the years. Chronic renal failure, as I said, could be hereditary. I've seen like intermarriages of different families, cousins. It's one of the things that I've seen working at Nicholas with, as I did clinicals there, I was into the dialysis room and they were telling me that sometimes it's intermarriage relationships. But again, as I said, it could be that lupus, look at that chronic glomerulonephritis or chronic pyelonephritis, kidney infections. All of these things can cause the kidneys just to stop working. So our goal with kidney failure, the chronic, is to have that kidney work as best as can. We want to also, because we worry about fluid, we worry about blood pressure, right? And electrolytes, we always have to monitor those. And oh, another thing is because of the erythropoietin, they don't make hemoglobin and hematocrit the way they should. So we can give erythropoietin sub-Q, and we could give that in order to have the body make its own blood cells. And that will decrease the amount of blood transfusions. And decreasing them even by one is a great thing. And with any condition in children, we want to make sure we keep a kid, try to keep them as active as we can. Now, one of the things that we can do for the newborn infant, the young child cannot have hemofiltration dialysis. They can't. Because when you pull the blood out and you push it in, when we pull it back in, it's too much flow and it will go to the brain and it will explode the vessels in the brain. So it will cause intraventricular hemorrhages. So we can't do it. The child has to be older in order to do the kidney machine. So what we do up to that point and what we're doing now on adults is starting them out on peritoneal dialysis. And they put a peritoneal cavity, they'll put a tube, just like this one here, and that is to remain sterile. You don't touch it, you don't connect it with anything unless you're sterile, you're capped, gowned, gloved, everything, because we need to protect that peritoneum, that cavity, because if it gets infected, where's the kidney? What are you going to do? There's no way for the urine to go, and it would be a death sentence. So we really need to protect that belly. So what they do with peritoneal dialysis, and I was actually certified to do peritoneal dialysis on infants when I worked at Nicholas. They have a machine, all these tubings, and they connect it to the end of that little white little tip on the end. As I said, all sterile. And they hook it up. And they have this diastolate or this liquid, whatever the nephrologist tells you they want you to use, on a warmer. And they'll tell you to put into the belly, usually an infant, 100 mLs, 150 mLs, and they put it in there and then they let it sit or still for usually half an hour. And then what they do is they open it and let it drain. Now, while it's inside that peritoneal cavity, it pulls out toxins. So by the time that 100 mLs goes into the Foley bag, which is where it drains to, he's collected more urine there. So we really, really watch this drainage and we make sure that there's no sediment, that the belly doesn't get red, that the color doesn't change on that urine. Because if we're seeing changes, guess what? It's probably an infection. So what are we going to do? Well, immediately you're going to call the doctor, the nephrologist, the doctor, whoever ordered it, because they need to be on antibiotics right away. Because if we don't save that abdomen, there's no place for a kidney. So what best describes acute glomerulonephritis? Which one?
B.
With the strep infection?
It is a strep. Yes, it is. Okay, GI has some crazy stuff in it you've never heard of before. It's one of those things. Remember, GI is mouth to anus and it involves everything with it. Okay. So, nutrition, is it GI? Yes. You eat it, you swallow it, you absorb it, you use it, the nutrients, and then you excrete what you don't need, right? So, where do a lot of nutritional disorders come from? It's your diet. So, vitamin, minerals you're getting that way. There are conditions that can cause a child not to get proper nutrition. Well, we know cancer, they're not going to want to eat. They get mouth sores and whatnot, and they're not going to grow properly because children need nutrition to grow. But HIV, same thing. They don't want to eat. Sickle cell disease, they're immunosuppressed. They get that way also. Cystic fibrosis, think about cystic fibrosis. The body cannot absorb the nutrients that it needs. And think about all those fat vitamins that it's losing also. And any child born at a low birth weight, we got to be concerned about, because normal 20-calorie formula ain't going to work. And breast milk, normal breast milk's going to need supplements. It's going to need extra calories in it for that child to grow properly. Because if you don't get nutrition, they're not going to be cognitively aware and they're not going to grow the way they should. Now, celiac disease. Celiac disease is all about gluten. It's all about avoiding wheat, rye, barley, and oats. And if they eat this stuff, the body goes into severe pain in the abdomen, and you are going to see these frothy, bulky, nasty stools, and this kid's going to be crying. So, what's the problem with the celiac disease? Well, they're going to have steatorrhea, which is that terrible, smelly stools. And it's because they are not absorbing fat. That fat absorption is not done and it goes away. Again, we're worried about fat vitamins in this child and nutrition. That general nutrition, they really have to do other things, take vitamins that are going to help them. And the only thing we do for celiac disease is all about the diet. Low gluten. Now they can have dairy, they can have fruits, they can have vegetables and meats and fishes. They cannot have wheat, rye, barley, and oats, breads, cakes, cookies, potato chips, all those things. But they can have rice. They can have potato chips because it's potato. It's not wheat, rye, oats. Or, today we're lucky. Everything has these labels: gluten free, gluten free. Think about 20 years ago, these children didn't have it, and parents had to guess. So there was a lot of hit and misses then. Today, we're not as bad. Even fresh made bakery items are gluten free for these children. Now, food allergies. Children are born and they're just on what? Iron fortified formulas and they're on breast milk. And then we start introducing food. And these children can have allergies. I mean, even some of the ones with formula, they can't have the milk based, right? That lactose intolerance. And we would see that with vomiting and diarrhea and abdominal pain and cramping and that is what you would see with that. So sometimes food allergies we see evident quickly with that, a little rash, maybe vomiting, diarrhea, but these are things that we need to pay attention to and avoid them. And that's why we don't give more than one type of food at a time when they first start. Now, GI dysfunction, they don't eat good. They're going to have a problem with growth, cognition, nutrition. They don't get it. They don't get all they should. You're going to have problems. And it could be that spitting up, regurg, like with GERD, right? Gastroesophageal reflux. It could be that vomiting, diarrhea, it could be constipation. All of these things can happen. Remember, the liver and jaundice is the common bile duct. It's all part of the GI tract. You might see things like that. And what about the kid with dysphagia? They don't swallow right. There's one condition called DeGeorge syndrome, and they got this tiny little jaw, and they have a problem sucking, swallowing, and breathing. And when they get to foods, they have a hard time eating. Many of them require NG tubes or G tubes. And we know fever, a kid won't eat, and they're losing fluid. It's all part of GI dysfunction. As I said, dehydration it could cause kidney failure in children. It's very, very serious, and it should be taken seriously. That's why many of the times a treatment for vomiting, diarrhea is number one fluids, 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 right? Whether by mouth, whether by IV. Now, fevers, we don't think about it all the time, but they're sweating all right. We'll give Tylenol, we'll give Motrin. Their fevers come down. What happens? The kid sweats and they run around and they're losing all this fluid, making sure that we replace it, right? And then we know vomiting and diarrhea. We're going to have to replace that. Diabetic ketoacidosis is all about dehydration. And then burns. Children do tend to touch things they shouldn't. So remember, they're losing fluids. I love these pictures. Look at these two infants and look at what you see. The one on top. Sunken fontanelle. Look at this child's color. Even his nose is pale, his ears are pale. There's no capillary refill. That child is severely dehydrated. Even the one on the right. And the other thing you see is these sunken eyeballs. And the one thing that really makes me sad, crying with no tears because they're so dehydrated. So, besides all of the physical assessments you can see, heart rate definitely is up, blood pressure's down, that prolonged capillary refill because blood needs to go to where it needs the proper organ, all your body's organs, so your hands and feet, it's not going to go there. Of course, your urinary output's going to be down because there's no extra fluid. And I said, cry with no tears. So, dehydration, number one, fluid. How do we give it? Well, depends on patient condition. Is the child awake and alert and not vomiting? Okay, we can give fluids by mouth. If they are lethargic, whether it's from diarrhea or vomiting, that's going to be IV. So again, patient condition. Now, how do we do that diagnosis dehydration? Well, all of the assessment, and we're going to do a basic metabolic profile. And we're going to look at the numbers and we're going to see. I mean, if they're vomiting diarrhea, let's look at those potassiums. Let's see where they are. So again, remember, fluid replacements we're going to give. And if they're at a low potassium, remember, no bolus of fluid should ever be with dextrose or with potassium. You don't ever bolus it. It should be Ringer's lactate, normal saline. Those are the two that, we always use for it. And if they're vomiting, give them something to stop it. The Donsteron is a great one, your Zofran, and wait 5 minutes and then start IVs or small slips fluids, whatever they need. Intake and outputs in for very important, you know, and we really need to pay attention. You know, do we measure sweating? Well, if it was getting severe and we couldn't catch up with it, there are ways we can be ingenious as nurses, because that's what nurses do. We could put a diaper underneath them and just weigh the diaper, right? You know, this is what it was dry, it was underneath them, this is what it weigh now, it's sweat. Again, but vital signs is going to tell you the urine, the stools we're going to monitor. And we know daily weights are, you know, very important. You know, they even come down to which scale did you weigh them on, and they're numbered. So to make sure it's that same scale. You know, there's some scales we really like and some that we don't. Well, in, you know, checking children, we just want to make sure the scale was the same. So there's no discrepancies because of that. And I love children, especially infants, because I can look at a fontanelle. You could see it. They're sitting there and it's sunken, and even they're crying and it's still sunken. You know, we're in a trouble. And of course, they're going to have some sort of alteration in mentation, a little confusion if they're older, only because you're not getting the blood flow into the brain. Now, there's all sorts of diarrheas for all different reasons, but it's all basically diarrhea. So, again, vomiting, diarrhea don't matter. We're going to look at the fluid electrolyte imbalance. We're going to look at the assessment, heart rate, blood pressure, capillary refills. We're going to look at that. And then with diarrhea, if at all possible, we try to go orally. They're not vomiting unless they're not conscious, or you know they're not alert enough, then we'd have to start an IV. And with diarrhea, we don't just give fluids. If you only give fluids, what's going to make that diarrhea firm up, right? Now, constipation can happen in children, and constipation sometimes could be a child's yell for help. There's things going on in the house. Do you know that their stools is the only thing they can control? I've seen them hold it for 7 and 10 days, no stool at all. And you do an x-ray and the whole abdomen is one big stool. And you're like, oh my God, that must hurt this child. But sometimes it's due to stress at home, divorce, moving, you know, many things, death of somebody, a dog, a parent, you know, grandmother, aunt, uncle. Those things really bother children, and they do react in their own way. And it could be by holding their stools. Now, not having a stool at birth is a trigger for us to check stuff. So if they're not having a stool, that means, and every child should have at least this black gooey stuff. That's the meconium stool. It's a great picture. And it is sticky and gooey just like it looks, okay? Not necessarily smells, not really, but it's sticky and it's gooey. And it sticks to their butts and you really have to clean it well. But that's what it looks like. If you're not seeing that, it could be an intestinal atresia. Atresia is nothing, no opening, nothing can go. Or it could be a stenosis, a narrowing of the passageway. Or it could be something called Hirschsprung's. We're going to go into that in a second. So Hirschsprung's disease. It could be a problem with the thyroid gland, could be hypothyroidism, or it could be cystic fibrosis. So if you're not stooling, they're going to do that x-ray, they're going to look, but they're going to be testing for CF, for cystic fibrosis, and they're going to be doing a thyroid panel, because these three things, the Hirschsprung's, hypothyroidism, and meconium illness from the cystic fibrosis, are things that we know that we wouldn't have figured out unless there was a history of them, and we'll be checking for them. So constipation, as I said, we know children do hold it, and we know that constipation is more prevalent in formula-fed babies. If you ever have had a baby and you breastfeed, they're always stooling. Almost every diaper, they're stooling. It's just part of breastfeeding. Formula feds tend to be tighter. So what do we do for constipation? Well, We're not going to be given enemas regularly. We're not going to be giving stool softeners, type things, laxatives. No, not in infancy. What we'll do is maybe the physician will say, give a little bit of apple juice or a little bit of prune juice or increase a little bit of fluids. Sometimes, if it gets to be longer, you might say to stimulate the rectum with a rectal temperature, and that can also have them stool for you. Now, peptic ulcers. You think children get peptic ulcers? Children are worriers. They do. They do worry about everything. And the way you treat an ulcer on a child is the way you treat an ulcer on an adult. Same thing. So first it's going to be diet. And we're going to be checking the upper GI, see what's going on there. And then we're going to be given maybe start with that ranitidine, Zantac, which now is Pepcid. They don't give Zantac anymore. Apparently, there's a lot of problems with that one too. And all Zantac does, it just reduces the acid, so prevents from getting ulcers in the stomach. And sometimes it's all it needs. Most children grow out of it, with diet, a little bit of meds. Some of them, they can do a perforated ulcer. They do have problems and have pieces of their stomachs removed. So it does happen. Rarely, but it does. Now, problems with the liver could be due to viral, non-viral, autoimmune, metabolic. It could be due to anything. So one of the things about children with liver issues, what does the liver secrete? It secretes a bile, right? What does the bile digest? Fat. If the liver's not working, are you going to feed this child a high fat diet so they have abdominal distension, cramping, and pain? No. So a low fat diet. You want to give high calories, high proteins, but low fat so that you prevent those things. And that's what I say about liver. Now, here's your Hirschsprungs. Remember, this is the one where you don't have a stool at birth. Another name for it is called congenital aganglionic megacolon. Now, look at that descendant colon on that picture, and it's big, right? It's aganglionic, which means there's no nerve cells. So there's no peristalsis, there's no movement. It sits there and gets big, and it creates an intestinal obstruction. Nothing goes past there, and it gets bigger and bigger and bigger, and they don't know because there's no nerves. They don't feel the pain. Now, you see that tiny little rectum, little pinpoint thing that sticks down? Sometimes a little bit of stool can squirt out in a ribbon, just like you're decorating a cake. That little ribbon thing, it's called ribbon stools. That you might see. So these could be, intestinal obstructions. They're not going to have stools at birth, or maybe little ribbons. So how do we treat Hirschsprungs? Well, they need to take out that useless piece of intestine, and they get rid of it, and they end up with a colostomy. Okay, give that child a chance to grow, and then usually by the end of the first year they reconnect it, so the child will have a normal intestinal flow by then. So they'll do a biopsy, they will do that x-ray, and they'll do that surgery, and they will end up re-anastomosing later on. Now, acute appendicitis, one of the most common surgeries in children besides tonsils and adenoids, right? Kids, you think of appendix, you think mostly of the younger children. So it's the right lower quadrant, McBurney point, guarding tenderness, lift the leg up, all those things. Those are what you see. Now, when you have a child come in, and these poor little kids walk in, if they're walking, their right hand holding their lower abdomen, and they're bent over and they're limping. And you're like, oh, that's an appendix. Number one, tell them stop eating, don't eat anymore. They will do an ultrasound, they'll find it, and the kid will go to the OR. Now, if his pain all of a sudden stops, he probably has burst. And now you are working with peritonitis. That is all of the stuff from that appendix inside the small and large intestines, that accumulation of material spewed into the peritoneal cavity, and it creates havoc in there. The intestines are inflamed and they're angry, and post-operatively, number one priority, NPO, nothing to eat or drink. Keep that intestine rest. We want to give IV fluids and IV antibiotics. Now they put an NG tube down because remember the stomach's still producing all that gastric acid, right? And it's going down into those bowels and the small and large intestines that are angry from all the stuff that's been all over the outside of them, and they don't want to be bothered. So they put an NG tube down, keeps the secretions out. They give IV antibiotics and IV, and of course these children will have pain post-op. Their tummies hurt. So make sure if we're getting them up out of bed, medicate them first. If you need to turn, cough, deep breathe, ambulate, make sure you medicate them first. These children do hurt. Now, one of the things we don't think about is remember that appendix burst inside the peritoneal cavity, which means that whole cavity is now dirty. And when they closed the wound for that intestines, when they were done in the belly, it was two dirty edges closed. So you have to watch out so it doesn't dehiss. You can dehiss a wound with a ruptured appendix. So monitor the wound, have that NG tube up, always monitor labs, making sure that white count comes down, making sure your potassium level's okay, especially with NG tubes sucking out these extra secretions, and of course, all the things we do post-op, turn, cough, deep breathe, up, out of bed, etc. Now, intussusception, interesting thing. This is when the intestines, it's usually children, those toddler ages is usually it. And the intestines are fine and they're running along. And all of a sudden, part of it gets sucked up into the other, like a telescope. It's called telescoping, and it hurts. These children, and sometimes it goes in, comes out, goes in, comes out. If when it goes in, these kids' abdomens are tense, their legs are spewing, these kids hurt. When I see these children like this, I'll put my hand, usually they're held by the mother, they're so bad. And usually if it's dad, they're holding them out because their legs are kicking so much. And I'll touch their little tummies and it'll be tense. And they tell me suddenly, all of a sudden, he's rolling around on the floor. That's intussusception. These children we send over to ultrasound, and we find it. And what they'll do is they'll do like a barium enema, but they call it an air enema, and they just blow out the intestines. Usually that works. And then if that don't work, they will take them to surgery. But only one in my career had to go to surgery. Most of them, they can pop them back out, put them on a high fiber diet, and they do well. Now, one of the signs and symptoms of intussusception is current jelly stool. So, along with checking the belly, peeking in that diaper, seeing that little current jelly, we have our diagnosis here. Sometimes these kids come in and they get to the room and then all of a sudden they're fine. This is a child that when you can't do an ultrasound, it's not going to work. And many of these children will send home without doing anything. We're going to say it sounds like intussusception. This is what you do. And if it continues, just come back. Now, a Meckel diverticulum, well, they call it a remnant of a fetal mesenteric duct. Just this piece of tissue that sticks up in the intestines, and inside that little tab that comes out is a big blood vessel. And it's usually small intestines, and it will rip. And maybe a little discomfort on the belly button, but not really. But you will see red stool. Painless red stool is what they call it. Painless rectal bleeding. And all they do is go in, they find it. It's this radionuclide study. It's hard to find, but when they finally get it, they'll do surgical. They'll just take that diverticulum out and they do okay. IBS, ulcerative colitis, Crohn's, mouth to anus, bits and pieces or the whole intestines, and it's all usually dietary, getting them proper nutrition. And then if it's a chronic condition, for instance, with Crohn's, they might need some biologic medications in order to calm the body down. But usually these children with diet do well. Short bowel syndrome. Well, you look at kids and things they go through. I'm going to tell you about Jessica. Jessica was a triplet. She was a cardiac kid. She was a bad hypoplastic left heart. So she already had her BT shunt at birth, came back at 8 months and was having her Glenn second stage surgery. Post-operatively, she wasn't doing well. She was on high level ventilators, et cetera, et cetera. But the belief was still to give a little bit of nutrition, keep that gut moving. Well, Jessica didn't tolerate it, probably due to some hypoxic episode event or something, and the gut didn't like it, and the gut burst. And that is called necrotizing enterocolitis. We see this a lot in premature and infants, where all of a sudden their bellies blow up and you get little ripples on them. And these children need that piece of necrotizing dead tissue removed out of their bellies. Well, Jessica had 58 centimeters of her small intestines was dead. Think about what the small intestines does. She didn't have much left. Short bowel. That means there's only this much instead of this much to absorb all their nutrients. So you can imagine the problem with nutrition with this child, right? Very poor nutrition. This child went home, Jessica. She was a triplet, so mom had her hands full, had a Broviac, hyperal lipids at night, G-tube during the day. And as she grew, she would be taken some by mouth too. No. One of the last kids I saw right before I left the hospital and just went pure teaching. She was skinny, but awake, alert, slight delay because of, oh my goodness, if you knew all she went on. But she did well and she was eating by mouth, was in school. She was in high school, a couple grades behind, but it was quite amazing to see short bowel syndrome and nutrition. And she was tall, to see that she, at least got that sort of nutrition. Another thing we can have is what we call gastroschisis. Gastroschisis, the belly is born on the outside of the stomach is born on the outside of the belly, and we got to get it back in there. And it is done. We make room, we hold it up, we push it back in. These kids are on their back, and we let by gravity force in, and eventually they put it back in. Hernias. We've all seen hernias, inguinal, or that umbilical. That umbilical hernia that you push in and out is squeezy and it's squishy. I used to always like to do it. Well, that means everything's great. But sometimes it can incarcerate, which means it twists, or strangulate. It twists. And it basically, that intestines will die if we do not go surgically in and untwist it, and make sure that it's positioned correctly. It could also be the diaphragm is not there. And this is one of your sickest infants, congenital, brand new babies born, usually they're full term. Their diaphragm didn't completely form and their intestines are in their chest. And these kids can't breathe. And the other lung is pushed over. So these children, just to ventilate them is a big deal. I'm telling you, a lot of work on these kids. I'm thinking of a couple in my head that I've taken care of. Usually they end up on ECMO, which is like a heart-lung machine. And they do surgery at the bedside to get those lungs down. But that one side, that left lobe, will never have lungs. We're trying to preserve that right-sided lung. These kids will always have half a lung. Malrotation and volvulus is just two different things where the intestines are twisted during whether the mesenteric arteries twist around it or the intestines twist by themselves. And these kids, again, they sort of act like an intussusception, but these kids will see them sick and with fever and prolonged and abdominal tenderness, but swelling. And again, it needs surgery because see intestines, they will perf because there's constriction. Some things that we see, and I've never seen one in my career. It's called an imperforated anus, which means this baby was born with no anus. And what happens is these children need to go to surgery to have a colostomy pretty quick because you need your gastric juices, intestinal juices to go somewhere. So there is multi-surgery repair where they can get an anus fixed again, but they'll never be totally normal there. And remember, with any development of child, whether it's female or male, there could be connections between the bladder and the stool. I've seen, and it's usually nurses who see it, where you're cleaning them and out of the vagina comes stool. Or out of the vagina, you'll see urine and it's not coming from the urethra. You're seeing something's wrong there. And it's usually some sort of fistula that they have to fix. Vomiting, how do we treat it? Well, we know that vomiting, if we can, if they're acutely vomiting, they're going to go NPO, you're going to give an antiemetic, draw a metabolic profile so you know where you're starting, and then again, IV fluids given to them, and then slowly introduce them to orals. Children eat everything and anything. Do you know what the most common substance that children love to take? Flintstone vitamins. I can't tell you how many times. Now, I've seen them take things like rat poison, those little Tide Pods, the younger kids, not the adolescents, you trying to be silly, but young kids. I have seen them take parents cardiac medicines and whatnot. I've seen them chew up Tylenol, chew up Motrin, but the most common of all is the vitamins. And what do we do for these things? Well, the first thing, even in triage, we're calling poison control. And we want to know the most up-to-date type of treatment. And that's what we do. And they'll tell us what needs to be done, what lab needs to be done, if they need to be admitted, et cetera, et cetera. I mean, we know Tylenol probably is the worst of everything because of hepatotoxicity. You're going to kill your kidneys, your liver, if there's just absolutely, we taken too much of it. And then always remember, in older places, kids love to chew on windowsills, and it could have lead paint. And these kids will get delirious on it and get lead toxic. Gastroesophageal reflux, GERD. Well, many kids get this little spit up all the time, right? And you're like, well, how do we treat it? Well, we know that burping them well, slow feeds, not overfeeding, sitting them up after, maybe in medication. These children might get some Pepsid or something of that sort to help them. Now, remember the importance of nutrition. And if they're chronically throwing up, their nutrition's going away. They might have to do something we call a Nissan fundoplication. Now, a Nissan fundoplication is where we flap over the top of the stomach where food, you cannot vomit. They usually use this for when you put in G-tubes, the gastrostomy tubes. They will do it as G-tube with a Nissan fundoplication. And that's to prevent them from aspirating, right? Well, in children, it's the most drastic of things. They've only seen one that had to get that far, but it does. It prevents them from vomiting. Now, sometimes the kid is older and they're refluxing. I've actually seen older kids, their back will arch because it burns coming up. And the other thing is an older kid and even adults, you'll hear this chronic cough, this is because their food's coming up to the back of their throat. They're having mini aspirations, and it causes that abdominal pain and that heartburn. Pyloric stenosis. Anybody ever hear of pyloric stenosis before? Pyloric stenosis is a fun one. Infant, 3 weeks, 3 months, something like that. The pyloric valve, it gets hypertrophic, narrowed, and formula cannot go down into the small intestines. So the stomach fills up, and then all of a sudden, this kid is going to vomit across the room. And watch out, point them towards the garbage can because it'll go 10, 15 feet. I'm talking projectile. So I get an infant that comes into the ER. They tell me my baby's vomiting. So I ask, is it dribbling or is it across the room? Now, if it's across the room, I know it's pyloric stenosis. I take my hand and put it underneath them, and right underneath their xiphoid process, there's going to be a little round, they call it an olive, I call it a marble. And it feels like a marble, and you can feel it there. And you're like, okay, so I'm going to tell them, do not feed your baby anything anymore. Because what's going to happen? They're going to vomit. So how do we diagnose this? They go for an ultrasound. What do we do once we get that diagnosis? We start an IV, we keep them NPO, and we send them up to the OR. Now, remember, this is a brand new baby. You've got parents that are like out of their mind with this. Usually, it's just they go in, they open up the pyloric valve, and they do well. The next day or later on, the kid's screaming, wants to eat. Small little pieces of clear liquids that they start taking. They can start eating, and they'll be watched for about 24 hours and then sent home. And they do well, and usually there's no outcome with this at all. So forceful vomiting, projectile, olive-sized mass in the upper abdomen, upper right abdomen, somewhere around there. Again, make them NPO, start IV fluids, and then post-op is clear liquids. Cleft lips, cleft palate. Many different reasons why it happens. Some are syndromes and some are just happenstance. Now, when we have a lip that's open, okay, we usually, that lip, remember, everything is self-soothing in the mouth, right? They can't put stuff in their mouth. They can't suck. They can't. This is going to create stress for that infant, right? Because everything is soothing in that mouth. So about 2 to 3 months, they'll do a plastic closure, and they'll close the lip. And they put that Logan bar, it's called there, so the kid can't smush it into the bed or anything, and it will keep that lip protected so it doesn't open up, because they want to keep everything approximated really, really well. So the lip, they'll do it 2 to 3 months. Now, it could go even further and go up, and it could be one side, both sides, and then it could be in the palate. The palate is usually done before 12 months, 6 to 12 months, somewhere around there. They want to do it before they start talking, because if you don't have all of these areas here the way they should, they cannot pronunciate. They won't talk like this because they cannot pronunciate. So, importance, this is done later, the palate, and then the lip is done first. Now, as I said, everything is oral. You got to feed these kids. Now, a mother developed these Haberman nippled bottles, and they're soft, very soft. And you put the amount you want, turn them over, and as that baby sort of sucks, and they will try to suck, you squirt a little bit in there slowly. and they eat well. Now, having a mother breastfeeding and trying to do it, I admire her because remember, they're going to be squeezing their breast to put that milk in because they can't, especially if there's a palate, they don't have that suction. So it's all about feeding. And then, of course, you're not feeding, growth problems. Now, esophageal atresia, tracheoesophageal fistula. This is all oral. That means the esophagus has no connection to a tummy, or the esophagus has a connection to the trachea. So if you eat, it doesn't go to the tummy, it comes up and you aspirate and you vomit, you choke, you gag. If they have the esophagus where it should be, but there's an opening between the trachea, you swallow, and guess what? Right into the lungs. You're going to be aspirating. So these children at birth, and sometimes it's they don't catch it immediately at birth. Sometimes they try to feed like glucose water or something, and they start spitting and gagging, and that will be that suspicion. These children, NPO, these children will be on an IV with IV antibiotics because no matter what, their mouth is mucus, they're swallowing it, it's going into their lungs, chance for infection. So IV antibiotics prevent them from pneumonia. These kids are normal kids, normally. They just have to have surgical repair. And they do it, and they do really well with it. And that's the PowerPoint. I told you, GI is weirdly crazy with the amount of different diagnoses there. It's trying to figure out which is current jelly, which is ribbon stools, which one's gagging and choking. And those are things I think that matching sheet really is going to help you with. So who wants to win the Kahoots tonight? Kahoot! Come on, Jonathan, it's your turn. I know it is. But I know who wants to try to win. These are 50 some odd questions. Should be about quarter after, I think. We'll be out of here. Anybody else want to join? I know it's getting to the end of the semester. We're all exhausted. I get you. I was in meetings since early this morning myself. I get you. Week 8, GIGU. All the following are symptoms of dehydration in an infant. Remember, dehydration in an infant is very serious, can cause renal failure. Pale, dry skin, loss of elasticity, weak, lethargic, increased heart rate, decreased blood pressure, capillary refill prolonged, maybe mentation. It could go on and on the amount of symptoms for dehydration. What is priority treatment for a child with dehydration due to profuse vomiting? So this kid is vomiting. It means this kid's pretty sick. And remember, vomiting, they're getting dehydrated, right? It says they're dehydrated. So what is our priority here? And this is IV fluids. If the kid's vomiting, we're not going to want to give oral. Are we going to make them NPO? Yeah, but priority is IV fluids. Replace the fluids because dehydration causes kidney failure. What is the treatment for an infant with diarrhea lasting for 4 days? What did I tell you about diarrhea in kids? Unless they are lethargic. Change in mentation. How are you going to treat it? And it's give them something by mouth. And you go to the hospital with diarrhea, they're going to be giving you Pedialyte, and they're going to tell you to take some lactobacillus until the diarrhea stops. And I've done it to my grandson, and it works beautifully. What acid-base imbalance may you see with a child who is having profuse diarrhea? Now, if you notice, I give you these acid-base questions. I mean, one of the HESIs, I think, had 4 acid-base questions on. So we have diarrhea and we have vomiting, and they're both different. And why? So profuse diarrhea has all of the enzymes which are alkaline in the large intestine, small intestines are being removed. So alkaline is gone. What are you left with? Acidosis. Let me converse this to vomiting. What do you have in your stomach? You have acid. You're vomiting, you're losing acid. What are you left with? Alkaline. So it'd be metabolic alkalosis. I hope this helps you remember that. It's one of the questions you're going to see. NCLEX, HESI, guaranteed. Multi. If an infant has not passed the meconian stool within 24 to 36 hours, what would you assess for? Remember I told you there's 3 different things that you need to look for, and we will. They're not passing stool. Why? Hypothyroidism, cystic fibrosis, and Hirschsprung's. Electrolyte imbalance, it's not what we're really going to assess for. Our main things are what condition is causing this child not to stool? Is it because the intestines is not working, or is it because of a condition like hypothyroidism or cystic fibrosis? Remember, if infant, aren't given proper thyroid hormone from birth, cognitively, they will be delayed. They need that thyroid hormone to be able to be normal. A deficiency of vitamin D causes what? What does vitamin D do for the body? Do you know that? I mean, I have issues with vitamin D with rheumatoid arthritis, with bones and joints. It's all about rickets. Rickets is brittle bone, and it's from vitamin D. So looking at that D, it has to do with joints, bones. Rickets has to do with that. A multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? Can't eat or drink, and they're vomiting and having diarrhea. What treatment? We're not going to give anything by mouth to a child unable to drink or eat anything. You don't want to make them vomit more. We will definitely do a metabolic profile. We want to know where we're starting with this dehydration, because if they're vomiting diarrhea, they are. And we're going to give IV fluids, okay? Nothing by mouth until we get that stomach calmed down. A multi. What nursing management would you anticipate for a child with a ruptured appendix post-operatively. So this child had an appendix, was in pain. Before they went to the OR, the pain stopped and it burst. All of that contaminant inside an appendix by the small and large intestine spews into the peritoneal cavity, creating havoc. So what are we going to do? Well, complete bed rest? No. This kid needs to get up, move around, and walk and ambulate. That's post-op care. Of course, we're going to medicate him for pain first. NG suction, keep that intestines empty because it's angry. Most important, IV antibiotics. And you're going to be looking at that surgical site because that was a dirty skin, dirty area closed up. And it doesn't mean it's going to get good blood flow and heal. And it could dehisce. So assessing that surgical site. Passage of urine, usually at night, in children who should have voluntary bladder control. What is that called? And it is called enuresis. Now, let me bring you to epispadias and hypospadias. In the male, at birth, congenitally, sometimes in a male, the urethra is not on the tip of the penis. It could be on the bottom side. That's hypospadias. So the hole isn't on the end, they urinate out of this side. And epispadias is on top, where they urinate out of this side. Now, they will repair this usually before they get potty trained. One of the things is they cannot be circumcised. That skin is used for the closure of the epispadias or hypospadias. Post-operatively, and this is they fillet the penis open, create the tube, use that circumcision tissue, cover it back up. They put a catheter in there. And usually that is left, we do nothing to it. We just put it in the diaper to catch the urine that's coming out of it. We don't flush it, we don't touch it, we don't roll it, we don't clean it, we do nothing. Leave it. And usually about 10 days after surgery, they pull it out. And these kids actually do very well. So I wanted to mention those things because you'll see questions on those. A multi. What is Hirschsprung's disease? Remember, Hirschsprung's is that big dilated intestines. It has no nerves or aganglionic. Okay. It can cause an intestinal obstruction because nothing can go down in there. Okay. And we need to take it out, put a colostomy there, and usually by the end of the first year, we're going to hook it back up again. A multi. When teaching parents about Hirschsprung's disease, the nurse would include what? Now, usually it is caught at birth, but sometimes it's not complete. And a little bit later on, they'll be catching it and because of constipation. So it will cause a bowel obstruction. You need to monitor those bowel habits. And as I said, it's a 2-stage surgery. Put the colostomy and then later go close it up. That's 2 stages. What type of stools will an infant with Hirschsprung's disease have? Remember, it's that big dilated colon, which goes down to a tiny little tube, which goes to the anus. What type? And it's called ribbon shape. It's like out of a icing, doing icing on a cake. Very good. What is a condition that occurs mainly in children when the intestines telescope into itself? Just sucks right in. And it's intussusception is the name of it. Made that one easy for you. Gastroesophageal reflux disease, GERD. What is that? Just look at what the word says, gastroesophagus reflux. So what does that mean? And it just flows back up in the esophagus. Remember, if we allow that continue on infants, they're losing too much nutrition. So we don't want that. And remember, older children, it's going up and down, up and down. You're burning that esophagus. It could create a lot of problems. And they will have that cough because of those little mini reflux inhalations. Inflammatory bowel disease involves what? IBS. Remember, IBS is, mouth to anus, anywhere in the GI tract, and it's anywhere in the intestines. What would the nurse be looking for with a patient who has Meckel diverticulum? That little outpatching little mesenteric duct that rips with this blood vessel in there. And they're usually pretty dilated, these blood vessels. And it's called painless rectal bleeding. Yes, good. A 6-year-old child goes to the ER due to abdominal pain, fever, and vomiting for the last day. What is assessment is priority? What do you need to know about this? I mean, they have abdominal pain or fever and vomiting, but what assessment do you really need to know? What do you look for first? You want to know, what is that abdominal pain? Where is it? Is it the right lower quadrant? Is it the belly button? Makes a difference on priority of care and how your acuteness. What would the nurse expect to see in an infant with biliary atresia? So there is no opening between the liver and the common bile duct, and you've got the liver there. It's not putting bile into the intestinal tract, into small intestines. So because that bile colors the stool, you're going to see those clay colored stools. And remember, what does bile do? It takes care of fat. And formula, breast milk, they'll have fat in it. When you don't have anything to digest it, your bellies get distended because you're not digesting it. And that's why abdominal distension. What structure of the mouth can be impacted by cleft lip and palate? So soft palate, hard palate, lip, all of it. One side, both sides, all of it. Cleft lip repair is typically done when? And that's the Haberman bottle. You see how it's filled up? And you sort of hold that bottom part with your fingers and slowly ease it. And the kid gets satisfied when they're drinking. It works great. So 2 to 3 months for the lip. Palate, later on. When does the cleft palate repair typically occur? Now you're going to remember this one. Remember, the lip needs to be closed because that's where they self-soothe in their mouth. So they need that closed first. The palate can wait, and that's 6 to 12 months. Esophageal atresia. What is that? Remember that little atresia, without nothing, right? Like tricuspid atresia, no opening, nothing. And that's the lack of opening between esophagus and the stomach. And it can be connected pretty easily. What are the classic signs of esophageal atresia and tracheal esophageal fistula? I put a lot of signs and symptoms in this question, which are other conditions too. Cyanosis, choking, coughing, because they're eating and it's coming back up and it's going into the lungs, or it's going down and into the lungs. So it's that cyanosis, choking, and coughing. Olive-shaped mass, that's your pyloric stenosis. Current jelly stools, intussusception. A multi. Neonate with suspected tracheoesophageal fistula. Nursing care should include what? I have an opening between my trachea and my esophagus. What do I need to know to take care of that child? I want the head of the bed elevated and they're going to be NPO. They are not going to be fed anything. And because they do have, no matter what, they're swallowing mucus, they're going to have these little mini aspirations, IV fluids, and antibiotic. Good. A 5-year-old is complaining of his epigastric pain and a persistent cough. What would you suspect? So this is GERD. This is reflux. This is what you'll see in the older children. And you'll still complaining that it is burning. And again, treatment for GERD would be starting with things like the Pepcid and diet, of course. What is ranitidine used for in a child with a peptic ulcer disease? And that just reduces the gastric acid. That's all it does. It does not neutralize it. You can't get rid of all of it. There's still some left, but it slows it down. It's not as much as it was. Signs and symptoms of a hypertrophic pyloric stenosis. That's that olive-sized mass at the midline. And again, remember projectile vomiting. Again, make them NPO. They'll go to the OR. Signs and symptoms of hypertrophic pyloric stenosis. And that's projectile vomiting. Really good. And you know something? It's not poor appetite. These kids keep losing their milk. They're hungry. They're screaming. They're crying. They want to eat more once they vomit. Preoperative treatment for pyloric stenosis includes so this is a child where you just keep NPO and you start IV fluids. You are not going to let them eat because remember, all they're going to do is vomit again. And it's not just IV fluids, it's both the NPO and the IV fluids. What does celiac disease affect? I worked with a nurse, and his son had celiac disease, and he used to bring in on the days of parties to the school a gluten-free cupcake or cake for that kid to eat because he couldn't eat what other parents brought. And I thought that was admirable that this guy did for his son. I'll always remember that. But celiac is the small intestines. It has to do absorption of food and intolerance to gluten. If you have celiac disease, what should you eliminate from your diet? And that's wheat, rye, barley's, oats, and there's rice cereal today, so we can use that to make rice flour to make all different things now. A multi. Vitamins that children with celiac disease are prone to lose are, remember those bulky, frothy stools? And they actually smell horrible. So when we look at these vitamins, they are all fat soluble that we lose. And it's A, D, and K. Vitamin C is a water soluble. That's your scurvy. What foods would you select for a child with celiac disease? Well, remember, celiac disease is all about bread type stuff, right? So when we look at these choices down here, which is stuff you can't eat? And there's one that you can eat all of it. Absolutely. Good job. No toast, no macaroni, and no bread. Good job. Phimosis. Didn't discuss it, but this is a male. It's one of those conditions that can occur. Take a guess. And what happens is they're uncircumcised and you cannot pull down the skin to clean inside of it. It's too tight. And that would be a child that would need a circumcision only because they can't keep it clean. That child would end up with a lot of urinary tract infections. It's not when it's pulled back. That is another emergency, but it is when the foreskin is too tight. What's a hydrocele? Well, hydro, water, fluid, right? Very painful. Sometimes causes incontinence in the male. And antibiotics is what's going to do it. And it is the fluid around the testes. What's a cryptorchidism? It's hard to put everything on a slide, so I do throw them in here. Cryptorchidism is when the testicles don't descend. Why do you think when you go to the pediatrician on first visit with a male, he is checking hips, of course, but checking the testicles? Are they down? Remember, if they don't come all the way down, testicles don't like the heat inside the abdominal cavity. They'll do surgery eventually to get them both pulled down. And the way you examine that is don't have them in a cold room because the testicles will suck up. Get them in a warm room, right? And then they'll hang down a lot freer. You'll have a better chance of examining them. You suspect an infant of a cryptorchidism. How would you examine them? And yes, put them in a warm room. You shake them and hold them tight. No, if it's warm, they'll hang down nice. And if they're cold, they're going to suck back up. So warm room, you'll get a better feel for the testicles. A hypospadias, or that's this one. And again, it's just knowing your anatomy and knowing the terms. And it's on the ventral side underneath. Epispadias is on the dorsal side. A multi. How is a hypospadias corrected? On the study guide that you have for the exam, put some really great examples of surgical pictures that you can look at and understand the gravity of this sort of surgery. It's a big surgery. So they use the foreskin, they put the stent in afterwards, and this is under general anesthesia. They take the penis and splay it open. They're not doing it under local. There's no way. It's not like a circumcision. What is a bladder exstrophy? We can have two things at birth born. One is gastrosthesis, or the stomach born on the outside of the body. The other one is the bladder is born on the outside of the body. And it's because the midline didn't close right and the stuff didn't get in there before it closed. Basically what happened. So one thing about bladder, you need to protect the skin and worry about skin barriers and keeping that skin clean. That bladder's still connected to, to the penis and the urethra. You're still urinating the right way. So urinary output and stuff is not a problem. It's now just protecting the integrity of the skin, whether it's the stomach or the bladder. What is the priority nursing care for an infant with bladder exstrophy? So again, it's worrying about the tissue and keeping it intact, because eventually we got to push this back inside. And it happens within a week of birth, usually, because infection is our big concern here. What are the clinical manifestations of nephrotic syndrome? Let me say it again. This is not renal failure. So it's just the kidney saying, I don't like your protein, I'm getting rid of you, and urinates out all of the protein. So you have hypoalbuminemia, low serum albumin, which is the same thing. And of course, these kids are swollen up. Absolutely. Children with nephrotic syndrome are often given what medications for fluid overload? Think about all of their fluid is extracellular because it's pushed out because there's no protein inside the vasculature, right? So how are we going to pull that fluid in and get rid of it? And that is your answer. So you give them protein, which is albumin, and we replace it intravascularly, and then you back it up with some Lasix, furosemide, and it pulls it out, and it will get rid of it. What is used to treat nephrotic syndrome in children? And it is prednisone is what we do. That's the treatment, but there's nursing care that we do a lot of too. A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? And that is a recent sore throat. Sore throat is one thing that can cause it, and that with a rheumatic fever. Those are the two things caused by strep. What is the priority nursing care of a child with nephrotic syndrome? So remember that all of their fluid is going into extracellular. They get rid of all of their protein in their urine. So how are you going to take care of these kids? What is your priority? Are they getting better or not? Absolutely. Daily weights. That's going to tell you, are they losing the fluid? That's what you want to monitor. Good job. Why is erythropoietin used in chronic kidney failure? Why is it used in cancer? Why is it used in many other conditions? Why? And it's all about making the body work for itself and to produce red blood cells more than it normally does. And again, preventing maybe a blood transfusion. A multi. Children with chronic kidney disease have renal osteodystrophy. What can this do to the child? What does osteodystrophy do to the child? Because remember, it's all about the vitamin Ds and all of the things have to do with bone structures. Osteo, bone, dystrophy, not normal. So it is skeletal abnormalities, that growth retardation, and it has to do with calcium, right? High parathyroid. Parathyroid, all about calcium. And that too much calcium can also cause those problems. A diagnostic finding of acute glomerulonephritis may be you draw labs on a child. What is the lab that shows you all about that strep that caused that acute glomerulonephritis? And it's positive anti-strep. So listen, get it? Strep is in there, ASO titer. Positive ASO titer, strep is in the body. And of course, that can be related to glomerulonephritis. Now you know the cause. What complication of peritoneal dialysis is most important? What did I tell you about peritoneal dialysis and getting all that extra fluid off the body that you want? What's one thing that you're concerned? And you don't want an infection in that poor little belly. That belly gets infected, there's no way to get urine out of that child. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? I had a kid who was out playing tag or something, and he ran around the corner sort of sideways fast and hit the hitch of a trailer right at the side of his kidney, his left kidney. And he came into the ER with this huge bruise, like really dark bruise on his back. Now, what were we concerned about? Well, fractured kidney is what he had. And we were able to diagnose this. That kid's potassium level was 7.6, I believe. It was huge. It was admitted and watched. The kid did okay. But remember, kidneys think about potassium. Very good. A multi. What should the nurse anticipate for a child who just had a renal biopsy? So renal biopsies, some of the post-ops, as I said, are very similar to your cardiac cath, which is monitor the dressing, which you're probably going to have a compression or a sandbag there. I&O, you touch the kidneys, you need to look at it, bed rest for 24 hours, and of course, check the belly, making sure that's not tender. But keep them in bed so that we don't dislodge that clot. What would you do if the fluid draining from the peritoneal dialysis catheter has changed color and is now cloudy? What is that telling you? So we definitely, at this point, we're going to say, doc, this is change, and they're going to say, okay, give antibiotics. They're not going to wait around for any symptoms. They say, okay, there's a change. Let's start antibiotic. Let's protect that peritoneal cavity. We need it. And last question, what would the nurse provide to an infant that cannot eat normally? How about that tracheoesophageal fistula? They can't eat, right? They're not allowed, but they're normal infants. We're going to give them a pacifier. Now, if they cannot eat, we're not going to put anything in their mouth at all. Okay? There's a reason why. We're going to aspirate it like on that tracheoesophageal fistula. So it's a pacifier. Remember, we must maintain developmental stages, and they need that. Number 3, John. Good job, John. You're up there on the podium. Did I too? Number 1. Yadi, you did it. 4, Amy, and I'm on 3. All right. Any questions at all about tonight? I tell you, it's a lot of different stuff in the GI and GU world that you don't think about. So if you guys don't understand it, let me know, and I'll be here to help you with it and understand it. I think that matching sheet really gives you everything you need, in a one little place for you to see. So anyway, that's all I got for tonight. Have a good one. I'll see you next week. Remember, next week we're going to have the reviews. So come visit us. All right. Have a good one.